Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFAL York Operations Coordinator. I would like to officially open the sixth session of our 2025 sessions in our Emergency Management in Hospitals and Healthcare Speaker Series, presented in partnership with the Thunder Bay Regional Health Sciences Center. I would like to begin today with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have longstanding relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Toronto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. The territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event, our participants may be joining from various locations, so I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speakers, and our participants from around the world. Welcome to our webinar. It is now my great pleasure to introduce Misha Richard. Misha Richard is the Emergency Preparedness Lead at Thunder Bay Regional Health Science Center and facilitator of the CFAL York TBR-HSC series and will be moderating the panel. For the sake of time, Misha's full bio and the full bio of all of today's speakers will be shared in the chat. Misha, thank you very much for moderating today's session and your ongoing help in putting together this series. The floor is yours.
Awesome, thank you very much. So we have a bit of an interesting structure for everybody that's attending today. I get to introduce our speakers, and after having some short presentations, we're going to jump into a bit of a more fulsome Q&A at the end. So first I'll say housekeeping. We have a Q&A. If you have questions that you would like our panelists to address, please ensure that you're populating them into the Q&A so that we can moderate those. But we encourage you all to chat, which is open and available for ongoing discussion of all the attendees throughout. And I'll start off by introducing our first panelist today. So not a new face to this series. Kassondra was one of our first speakers in the past. So I want to welcome back Kassondra Stockman-Sousa. She is the Emergency Preparedness Advisor at Halton Healthcare and has been with the organization since 2013. She has been directly involved in emergency management planning related to the completion of 3 major capital redevelopment projects, including the construction of a 1.6 million square foot hospital in Oakville. She's passionate about fire safety and a dedicated advocate of both personal and work preparedness. She has a Master of Forensic Science from George Washington University and is a DRI International Certified Business Continuity Professional. She also holds the Halton Emergency Management Certificate at master level. So thank you very much for joining us today, Kassondra. Next, I'll introduce Dr. Delwin Ferguson. Delwin's the Emergency Preparedness Manager with Nova Scotia Health's Central Zone. As an Emergency Preparedness Manager for the zone, Delwin plays an integral role in ensuring the healthcare sites within the zone develop and strengthen their emergency response capacity, streamline their business continuity process, and build resilience to handle critical incidents and events. Delwin holds a Master of Public Health from the University of the West Indies and his PhD from Walden University. So thank you for joining us today, Delwin. Next, I get to introduce his colleague, Chris Khokhar, from who's an emergency preparedness consultant with Nova Scotia Health's Central Zone. This is where he supports healthcare facilities in strengthening their emergency response, business continuity, and resilience to critical incidents. Chris holds a Master of Arts in Disaster and Emergency Management from Royal Roads University and a Bachelor of Arts in Sociology and Philosophy from the University of Windsor. He's passionate about cross-sector collaboration, values-based leadership, and leveraging innovation to address evolving risks, such as climate-related emergencies and air quality threats in healthcare settings, which is very fitting to have Chris with us today on this panel. And last but certainly not least, and also a returning face to the series, we have Andrew Moull. Andrew is currently serving as the Manager of Emergency and Disaster Management at Hamilton Health Sciences. In this role, he leads preparedness and response initiatives across a large and complex healthcare system. He also contributes to academic development in the field as a co-course director at York University's Disaster and Emergency Management graduate program. Andrew is also on the resource committee of the Association of Healthcare Emergency Preparedness Professionals, or AHEP, where he helps organize the Canadian chapter. and he holds 2 master's degrees, one in history from the University of Waterloo and another in disaster and emergency management from York University. So thank you very much, everybody, for joining us today. Recognizing that not everybody on this is familiar with healthcare emergency management, even if you've been following along, gives me an opportunity to actually share my screen and give everyone a brief overview introduction to today's topic, which is code gray air exclusion. So if you will permit me, I'm just going to share my screen here. So hopefully everybody can see my screen. Somebody give me a shout out yes from the panel. Okay.
Yeah, it looks
so perfect. So quick, 1 second. Can everybody still see the screen? Feel like I got a little blurb there.
no, it went away.
Oh, gracious. Let's do this again. Pardon me, everybody. We already tested this out, and this is not my first rodeo. Okay, can you see my screen?
Yeah, that looks good.
Perfect. So the quick history, hospital emergency codes. If you weren't familiar, back in the 90s, the Ontario Hospital Association Board of Directors endorsed emergency color codes. The goal was to reduce the chance of human error and eliminate, some confusion among hospital staff during an emergency. These were adopted across Canada as well. And today's topic is code gray button down or air exclusion. You'll notice there's 2 code gray categories, which is why we wanted to chat about this and just explain what we're using as this sort of historical baseline here. So what is a code gray air exclusion? So typically it's viewed as being an emergency code that comes about when we've determined that the air outside is a danger to the people within the building. So this could be triggered by a variety of reasons, but perhaps a large smoky fire or release of toxic chemicals. An alternative to evacuation where the potential for exposure is short term or where evacuation is not practical or cannot be carried out quickly and safely. Thinking about the fact that evacuating a hospital is something none of us want to have to do. Typical response actions are things like air quality monitoring, sheltering in place, and canceling some procedures or appointments. And sometimes you'll hear this code gray, referred to as button down or shelter in place as well. So why is this important? Well, we certainly see incidents. Statistics Canada has some pretty big numbers about dangerous goods that are reported to Transport Canada, for example. So we see a lot of these things make headlines. And obviously, if you're a healthcare facility that's located in close proximity, these types of incidents could trigger some sort of air exclusion response within your organization. Little snapshot there that there's more than 450 incidents that got reported to Transport Canada, and the majority of those were ones that occurred on roads. The more you know. Why is emergency air exclusion planning important? Just from the perspective of, hey, different communities will end up issuing shelter-in-place advisories or orders, and those are going to also apply to those of us that are working in healthcare settings within that catchment area. So these are just a couple of items that got pulled from recent headlines, including a facility that had pool chemicals that had caught fire and created an enormous plume, all the way to some other advisories triggering shelter in place. And then again, why would we consider something like a prolonged hazardous air quality planning element being important? So not having a train derailment next door that is hopefully resolved within a certain period of time, perhaps something that is much more protracted. And this is where we get into considerations for wildfire smoke, especially tied into things with severe smog as well. And so one of the headlines that we pulled out in the front was highlighting to those, again, who are from outside healthcare, that poor air quality can impact our actual service provision in hospitals. And with a changing climate that's expected to exacerbate wildfires, it's something that we have to plan for more and more. And so what do the latest Accreditation Canada standards say about hazardous air-related incidents, as my last slide? Not that anybody can put up their hands, but I'll give you the key reference here. Organizations are to establish regularly review and update as needed policies and procedures for shelter in place and lockdown. And where this ties into the topic today is the comments about if we need to shelter in place because of environmental contamination, for example, hazardous chemical release, we are obligated to have policies and procedures to isolate the internal environment of our hospital, such as by shutting down heating, ventilation, air conditioning, sealing vents, doors, and windows, and so on. So this gives you an overview of our current environment in which we're operating, as well as the considerations for our emergency color code requirements and Accreditation Canada standard considerations. So I will stop sharing my screen. And now, with that quick overview, before we get into any questions, of course, I want to remind everybody, if you have any questions for the panelists, please put them in the Q&A. So now I can turn it over to Kassondra. You're the first one that's going to give us a quick overview of some experiences at your organization. So thank you. Floor is yours.
Okay, is my screen showing? Perfect. Okay. So I do apologize, everybody, for my scratchy voice. I'm actually look like I'm sick from the smoke event we had this week. So it was kind of fitting. I'm here, but I do apologize if I have to stop and just drink some water. Oops. So just to talk about the air quality response plans of Halton Healthcare. But first, just to have a quick idea, we are to the west side of Toronto. We're kind of between Hamilton and Toronto. And we have 3 hospitals, so Oakville, Milton, and Georgetown. And we do, of course, also have several community services that we also support, including we do actually have one in Burlington. We have had some major capital projects. So obviously our largest one was our new Oakville Hospital, but we have actually done a large expansion as well at Milton Hospital, and that one should continue to be expanded, and we'll see what happens to Georgetown in the future, as we do have a lovely piece of land to do some development on now as well. So what are our emergency codes? So for us, we do have code grays. It is broken out into 5 plans, and one of those is our external air exclusion plan, which we do this time still call button down. We also do have a new plan that's not on here because it is in our trial phase for the summer, and that is our severe summer weather response plan. So how do those 2 work for us? So with our code gray button down, this is meant to be our response more to the release of toxins, so those chemical leaks, the fires in the environment. And this is where we do have the procedures for shutting down our building's air exchange systems, locking the permanent doors, otherwise really initiating that sheltering in place at the hospital. It does tie into what we call our hold and secure procedure. So that is our plan that we have for locking our perimeter doors of our hospital. And that is now involves also setting up a checkpoint, because we can't really contain people into a building as they are adults. So we do have to let them out, even if they want to go out into the toxic air, that is their choice. So we do have a plan for how we initiate that, and only have one place that this can be done at to try to protect our hospitals as best as possible. What we have created as well is the severe summer weather response plan. And one of the sections we did add in here was an air quality section. And this was obviously just to go around the basic air pollution, but really as a result of all the wildfire smoke that we have been experiencing starting last year, we were really noticing a lot as well. And we do a lot of the response here based on the air quality health index that is sent out by Environment Canada. So it does have triggers based on the numbering system that comes from there. So luckily for our hospitals is we've never had to activate a full-on code gray button down, which is great. We are actually along train lines, especially our Georgetown Hospital is actually very, very close to one. Milton has some pretty big chemical stuff right nearby, and Oakville does have major laneway, but we have been very lucky from that extent. However, we have had an initiated our air quality responses this year. And that has been, of course, also for the wildfire smoke. And we do have 2 levels. So we do have it when the quality is the 7 and 9, and then we have the 10+. Really the main difference in these though is discussions with our facility teams on if we're going to do any extra steps. So if we're looking at a prolonged 10 plus, there is some extra work we may be doing to the filtration systems, adding some extra filtration in for the to help with the air quality coming into the building. So we do handle it a little bit different from how we might do from a button down. Now, recently we did almost look like we might have had a code gray button down. There were actually a really large grass fire that happened along the train tracks very recently and got quite close to our Oakville Hospital. And while we were sitting in the EOC for a different event, it started to smell very smoky in the building. And we could see the smoke out the EOC window. But just as we were sort of about to call the fire department and get some further information and see what we should need to do, it looks like they got the fire under control and were able to extinguish. And we kind of got around that one before it actually had to happen. So that was good because we literally were all laughing. We were just about to leave the EOC and kind of hung out to make sure we didn't have to reactivate. So I put questions, but I know we're not doing them now, so we can kind of ignore that. But yes, that's just a quick high level. I wanted to make sure I got it quick, so I'll wait for any questions that specifically come through to me at the end.
That's perfect. Thank you, Cassondra. I also wanted to note, I threw in the chat for everyone's awareness that talking about the AQHI, so Canada's Air Quality Health Index, you're probably going to hear a lot about that through today's talk. And that's based on a few different pollutants. One of them is particularly high in wildfire smoke. There's been discussion around whether we should have some changes to our air quality health index to be a little bit more reflective of that kind of impact of the amount of particulate matter. But again, just for awareness, the Air Quality Health Index, AQHI, you will probably hear that referenced again in this talk. So now this is an opportunity for our peers here from Nova Scotia Health to jump on and share one of their experiences. So I'll wait to give you the thumbs up that we've got the screen sharing. Perfect. Delwin, I can see your screen. Great. Thank you. Over to you.
Okay, good afternoon, everyone. I am going to share one of our experience that we have that impacted one of our sites in the Halifax region, which is the Victoria General. So I'm going to quickly describe the scenario of what happens and what we did, and then I will hand over to Chris, who will carry you through some of the actions that we are now following up on. So on May 30th this year, about 8 o'clock in the morning, we received a call from the Halifax Regional Fire Dispatch that we should shelter in place, get all our patients and staff from the parking lot. We should also turn off our air handling unit and ensure that our parking lot is clear. A sequence of activities that take place, 8:56, I, as the emergency preparedness manager, receive a call from the fire dispatch as well, indicating that there is a gas leak. At the time, there was a little bit of uncertainty whether it would be butane, propane, or natural gas. They were not sure of what was the gas that was leaking. So what we did, we immediately notified security to implement access control, not a full lockdown, ensure that everyone would come in from the parking lot. At the same time, I continue to work with the leadership just to communicate what we have just received and so forth. We also touch base with our facilities maintenance and support team that the ventilation system would have to be shut down. And then I circled back to talk with our leadership, notified everyone of the problem that we have. Still waiting on the fire department to give us a further update of what was happening. So just to give you a context of the Nova Scotia Health, in the central zone, the Victoria General is one of the leading site that we have. So right here, you can see the Victoria General Hospital. Close beside it is the IWK, if you see where my cursors are moving. And just a straight line to show you how close it was, which was about 330 kilometers away, was that natural gas leak. To put in context of what would have been our problem, these are just some of the buildings that is in that site. We have the Bethune building with approximately 100 staff, different clinics. The center in The inpatient unit, it covers our OR and our ICU, etc. And the Center for Clinical Research, the Dixon building. Overall, we're looking at pretty much 2,000 patients and staff impacted if things should go wrong. So the action that we took at 091, security implemented the access control, not a full lockdown. They made the announcement in all the buildings. They manually started to lock some of the doors to ensure that no one can get in or out and get everyone inside. It took 5 officers to get all of those buildings locked, and everything was secured about 25 minutes thereafter. In the meantime, from an emergency preparedness lens, what I did was have a 3-way call between the site lead, the FMS manager, to indicate what we have just received from the fire department. We discussed the fire order. We discussed also shutting down that ventilation system and what would happen, how it will impact those persons that are inside, the air quality. From that, we recognized we need to get occupational health and safety. So about 9:05, they came on stream and we started to think about we need to start monitoring the air quality inside since the ventilation system will be shutting down. I then went and notified our senior leadership team of what is happening. The facilities maintenance about 9:06 decided to communicate to all of their team that the ventilation system for all buildings need to be shut down. This took about pretty much 40 minutes to get the full system shut down. So about 9:45, they reported back to us that the ventilation system was shut down. So that was just a quick summary of what happened. So I'm gonna let Chris now talk about some of the challenges that we face and what follow-up actions we are now carrying through. Chris, over to you.
Thank you, Delwin. So now that we understand the scope of the incident and the potential consequences, we can look at what are key challenges that we derived from the incident. So one of the biggest that we discovered was the limited number of security staff available to manage and secure the multiple entrances across such a large, complex campus, right? So that was an issue that we identified and have improved since. They will be making requests to our sister site, which is neighboring, and they have developed a collaboration piece in a future incident for that. We also saw that patients and members of the public largely ignored municipal alerts, which reduced the effectiveness of our shelter-in-place order that we were initiating. Our municipal alert is the HFX, which is our official Halifax emergency alert system, which sends an alert via text, phone call, as well as email. Another challenge was smaller sites. Fenwick, which is in a closer proximity to the actual gas leak, wasn't included in the initial notification. We became aware of that very quickly, so we were able to reach out on our own and make that connect. I see that we lost our screen sharing. Luckily, I still have it open, so I can still go through our notes and still respect the time, because I know we are on that time limit. There was also some confusion between access control and lockdown language and steps being taken. Now, I know from speaking with colleagues across the province, this is not unique to Nova Scotia. So I imagine that all of my colleagues here on the panel probably experienced similar issues in their sites. So that just gave us a spotlight for continuing education and making sure that we are explaining and detailing what that language difference is. What else? We also have patients being redirected to Dixon, one of the buildings. So redirecting patients between buildings was somewhat problematic, especially when sites like Dixon where one security guard at Dixon was refusing entry from the redirection, right? So again, back to training, not just for our healthcare staff, but also for our security teams around what the different approaches look like for access control versus lockdown. And lastly, I know Delwin touched on this, but was the ventilation shutdown process, which we discovered is very time consuming. It involves 150 air handling units, with 200 screens, relies heavily on the availability of HVAC technicians. This incident highlighted this issue to us, and we've since addressed it with our FMS team, which is our facility management systems, and they are compiling, streamlining that process for future incidents as well.
That's great. Thank you very much for the overview, Chris. I know I gave all of the panelists very tight timelines to present an overview of an experience that they've had recently. So again, everybody in the audience, stay with us. You will get to ask your questions. We will have the panel. Now I get to turn it over to Andrew to tell us about an experience that he's had before we can kind of open the floor. So Andrew, over to you. Wait, you're muted,
There we
Andrew.
go. Now I'm unmuted. All right. Good afternoon, everyone, or good morning still, depending on where you're chiming in from. So my name's Andrew Moull, I'm the manager at Hamilton Health Sciences, and I got 3 small, quick case studies to go over, just because the city seems to have a lot of events, and we're not a wildfire hazard, so that makes it super fun. So a little bit about Hamilton Health Sciences. We're located, obviously, Hamilton, Ontario, just at the bottom corner of Lake Ontario. We have 5 research and teaching hospitals and 6 major outpatient research centers and clinics. We serve around 2.3 million people in our catchment area. We do have Canada's largest NICU, inpatient mental health, and palliative care programs. And our whole team's about 18,000 staff, physicians, and volunteers at this point. And our emergency management team is myself, a specialist, and we have 250 volunteer code captains to help kind of try and stay on top of everything. So Hamilton, for those who don't know about our wonderful city, we have a massive industrial sector, probably one of the main industrial hubs in Canada, certainly for steel production, among many other things. And so here's just a quick risk profile. I'm not going to go through all these, but these are 4 of the most common known chemical hazards that we have in our area. The proximity, in particular, to our level 1 trauma center, the Hamilton General. The train tracks is about 50 feet behind the building, to the point if I'm in a back office, I can read the labels on the train. So it's always a concern, and the hazards ever present. Funny enough, none of the incidents I'm going to talk to you about, though, deal with chemical. So far, we've avoided one slightly chemical related, but so far we've avoided this. But the risk in our community is quite high, and it is always top of mind, both with us and the city of Hamilton. So the first case study, the Mr. U's tire storage fire. This happened back in 2020 during COVID. And so major fire occurred at a tire storage facility. You can imagine how that goes with those types of materials burning. And initially, the wind started blowing off the lake back towards what we affectionately here call the mountain. It's really the Niagara Escarpment. But we have 2 hospitals in the path of the fire, which was our St. Peter's site, where I'm based out of, and then the Javinsky Hospital and Cancer Center up on top of the escarpment. So we were notified by the city, which I think the key takeaway for us with this incident was just affirmation of our relationship with city emergency management and our communication. It works very effectively, and they do keep us appraised of any threats going on in the community that we need to know about. And so we did put our St. Peter site initially into a code grade button down. So I'm not going to repeat. It's very similar to what Kassondra overviewed for her plans. So we did put it in effect. We have 3 stages: alert, standby, and in effect. And so the Dravinsky also went into standby because they weren't seeing the smoke yet. But we were making the preparations to start turning off air handling and securing entrances. Thankfully, the wind shifted shortly after the fire was blowing over St. Peter's, and so we were able to downgrade from an in effect to a standby, and then the standby to an alert at the Jervinsky. And thankfully, it was short-lived. No real major impact on services, but the review did indicate some improvement internally for notification and a bit of familiarization. It's one that obviously we don't deal with too often. So getting leaders to understand why we're restricting access and turning off air handlers, always a good refresher. And then also it was really almost a drill in some senses where we got to practice getting all our access points secure and also how long it takes to turn off air handling. Next was a bit of an internal issue. We had a car fire in our underground parking. And so that are McMaster Children's, and for those who've never been to our wonderful little children's hospital, the parking is right underneath the site. And so the location of the fire was such that there was an air intake vent right in the pathway of the smoke. And initially, no one pulled the pull station in the garage, and it wasn't really triggering a smoke alarm yet. So the smoke went through the air intake and into our operating rooms. And so we had to shut down our operating rooms for, I believe it was only a day. They were very quick, obviously, to get those back up. It is a pediatric trauma center, so we do not want those offline for too long. Um, and it did take more than 13 fire extinguishers, and I think I ended up having to get a hose on it to actually put that car out. But it did reveal a number of issues. One, we included internal causes of air exclusion as a consideration in our button-down procedure. And then as well, reviewing of our activation pull stations and also education for patients and visitors. Notification of engineering to get the air system turned off, and reminders that, extinguishers are great for garbage pail size fires, but probably not as effective against a fully engulfed car fire. And as you'd expect with the ORs being impacted, we did have a number of surgeries delayed or canceled until those got back up. And then just very, very short touch base on probably the most infamous, still probably the most infamous disaster in Hamilton in recent memory is the Plastimate fire of '97. The plastics recycling facility went up in flames. The brown building at the lower right-hand corner of that picture is the Hamilton General. So it's about 2 blocks away from the fire. I was able to interview staff who did work that day or those days. Funny enough, everyone seemed to either be on their first day or first week on the job, as so happens in our field. And so this was before emergency disaster management existed at the hospital. Plans were very light in terms of guidance. They ended up sheltering in place for the full day. Significant discussion on whether or not to evacuate the site. And what those risks would be. Firefighters were able to tamper the fire down enough that they didn't have to worry about evacuating on the following days. But it really kind of started the foundation of developing a more wholesome shelter-in-place plan for the organization from information I've been able to find. And then as well, just the impact on the local community. A number of firefighters unfortunately got cancer. And it had a huge impact on fire safety, not only in Hamilton, but in Ontario. And it's still kind of folks here will still remind you about the Plastimate fire if you give them a chance to talk about it. So I'd be remiss if we were talking about air exclusion to not touch base on the seminal event for our community. And that is my crash course on my experiences with Code Gray button down. So I hope that was within time.
Everything is within time. I'm so proud of everybody today. Despite some technical glitches, we have now received, a handful of different case study examples that are stemming from multiple sources. And it's a part of the reason why you wanted to have this panel together. Everybody's experiences have been different, though there might be some commonalities thread throughout. And also touching on the urgent need to shelter in place, which we had discussed as far as, having that notification from your community partners saying like, this is what is in effect, versus our protracted scenarios where hearing Kassondra talk about teasing out and pulling kind of the weather and air quality response measures into their own policies and procedures, and taking it away from being this button down for sort of urgent, time sensitive sheltering in place situations. So one thing that I wanted to bring up now that we've gone through some of these examples that folks can refer back to is internal monitoring. So Chris and Delwin, I think I heard you gentlemen talk about bringing in your OC Health team to support in like air quality testing within the facility. I'm curious, who has permanent devices? What does this look like for air quality monitoring inside the hospital, especially when we're thinking of protracted situation? I think for folks that are attending, just for point of reference, where these air quality monitoring stations are in our community does not immediately tell us whether the air quality is safe inside the hospital for our patients and for things like carrying on surgery. So who does what for air quality inside the building? Anybody want to shed some light on what your process is like?
Okay, I can take that one for you. In Nova Scotia Health, the Occupational Health and Safety has some, I am not too sure of the exact numbers of staff that are occupational health hygienists that are employed to that team. It's a small number, so let me just say that first. They have the portable occupational monitoring, air quality monitoring that they will use to measure. And FMS, if the occupational health and safety hygienist does not have the enough monitors to measure and to give the accurate reading in a timely manner, they have a group of private contractors that are on standby that they can reach out to, so we can quickly mobilize them. I can share that over the last 3 or 4 months, because of a redevelopment project that we've been doing, we have been using quite a few of those private contractors to monitor the air quality within the building itself.
Yeah, it's one of those questions for anybody that's dealt with wildfire smoke. You start being asked by staff inside the building when they can smell it, what does that mean when we can smell it inside? Doesn't necessarily mean that it is unsafe, especially depending on what activities are taking place, but immediately everybody's noses become very sensitive here. That also leads me to another question, which is, we were talking about access control, and as Chris pointed out, there is no single standard for essentially what lockdown might mean across our organizations. But I heard some use of hold and secure. We did talk about shelter in place. We did talk about access control. We did talk about lockdown. So for these procedures, what level of locking down of your facilities is actually taking place, and what language you're using? Is that in alignment with law enforcement, municipality? How have you landed on the terminology and how you're securing? Anybody want to jump in on that one? It's a big, multifaceted.
I can go.
Great, Kassondra.
Yeah, so we do have the hold and secure is what we call it here. So that's securing perimeter doors for us. It's standalone plan, but embedded into multiple other codes. So it may activate that plan as part of another response. So we use it for code ambers. We use it for the code gray button downs. It could just be done because the police have called and have a big problem in our parking lot and want us to go and hold and secure. We have worked on it with police to match the terminology that they use for schools. So you hear that a lot where there's a gunman in the vicinity. So they go into a hold and secure the school, which means our perimeter doors are locked, but we're still free to move within the building normally. So that's which is what they do with the school. So we just use that similar definition. And they're good with that. We don't actually say it overhead though, the terminology hold and secure in that sense. We give a description of that we've locked the perimeter doors and what that means for people in the building. And then we will set up a checkpoint. So everything's locked and everything gets funneled through one entrance. We have 2 entrances chosen, so obviously it's dependent on the event and which one makes the most sense for safety reasons. And our security team will make that determination. And then what is it that they're checking? So is it related to an air quality thing? Then we might not be checking anything, just letting people in and out. But in that case, we might be more on the out, explaining why we've locked the doors and seeing if they really do want to go out. So that's kind of how we have that one set up for us. Sorry, and I should have said, sorry, for the air quality portion, we don't actually activate a hold and secure right away. That's where the assessment would come in afterwards to determine what the needs are for the event. One of the things we do consider though is locking or turning off our revolving doors, just because they can suck a lot of air into the building and stuff. So those ones do commonly get shut down for an air quality. That's one of the reasons we did develop the plan too, that our P3s are very happy with as well, because it gives them a little bit of trigger points that they can base on the plan. So there's not this go back and forth between these contracted maintenance departments. So it gives them a good trigger point that they can use right away to make the determination for that need.
So you've used the magic word that I was going to bring up next, which is perhaps the precursor to saying, how do you lock down your doors and what is the terminology you're using is, what is the trigger and who is actually initiating this? So certainly for something that's a protracted air quality issue, there's got to be a certain threshold there that's met, versus in the case of, Andrew talking about this recycling plant fire, you're getting that immediate notification and you can visually see this plume of black smoke, 2 blocks away. So what are the thresholds for your organizations to actually secure your perimeter and shut down your air handling units? What does that look like?
Yeah, so for code grade button down, they are commonly they might be called in directly from our fire department for an event. We have very good relations with our fire department, so they have called us for stuff before. It could be something that's seen, so the alert would come through to usually to my department. But we would work with the leader on call and the executive leader right away to make a decision. But our security team does have the authority to initiate it should they need to, based on what they're receiving and seeing. From an air quality perspective, we do have what we call a severe weather response team. So that team just gets together and does a discussion and assessment, because usually it's not the same emergency trigger like we mentioned from a code grade button down. We usually have a little bit of wiggle room and time. So depending on what we're getting reports from with the QHI reports, then we will get a team together and we'll have some discussions on what further actions we may need to take.
Anybody else want to pipe in about how you're doing things in comparison to what's happening at Halton with Kassondra's team?
So we're very similar. I guess the one kind of point I'll add is we keep ours very flexible, and we haven't really fully incorporated the air quality aspect into it. It's on our to-do list, but certainly when dealing with the acute ones, it comes down to understanding, what are the current wind patterns and projected wind patterns. What's the threat? Easy things like turning off your automatic doors and having folks use manual ones is an easy way of controlling in some of those areas where we've had recently with the wildfire smoke. We've had people in the ED mention they can smell it, so we're able to mitigate that by just turning off the automatic doors, which anytime you walk past them opens up, sucks air in because of the pressure changes. But we really tried to design it to be as flexible as possible and not behold it to, well, we're not at this threshold yet. And we wanted to empower, it's through our OC Health, my office, and the facilities management with input from security that we'd probably make that decision. But we've purposely kept it fairly nimble and loose by design.
And Delwin, it looked like you were going to jump in.
Yes, I was about to say, similar to Cassandra and Andrew, we have implemented similar process. The difference is that we have broken access control and lockdown as two separate terms because it tends to bring a lot of confusion among staff. So recently, I would say since January, we have been going through all of our sites across the province, educating staff when to use access control, which means that you're monitoring the entrance and exit and you're keeping a check of who comes in, who goes out. When it comes to lockdown, we have strict guidelines. The doors are closed completely, and the decisions of a patient who is critical coming in is the decision of the site lead itself. In reference to the triggers, we have started to build a strong relationship with the fire department. They will reach out to us to give us a guidance as to say, hey, this is what is happening in your area. We will get our occupational health and safety team to be a part of that discussion with us to say, hey, this is what we have got from the fire department. This is the areas of concerns that we have. What do we do? So the guidance really comes from the fire department and the OHS. And we then take that to the leadership and start to implement what needs to be done.
Yeah, I think it's very important that we're highlighting, obviously, our community partnerships and those relationships with our first responders like fire for a lot of these urgent responses. There was a very good question that popped up in the Q&A that was asking about when we have differences from, lockdown, where we view that as often being related to some sort of tangible physical threat. So, some sort of violent individual, for example. Speaking of hold and secure access control is not directly tied to a threat to the individual in relation to how are we securing the perimeter doors? The question was, can any of the staff, is this something that's just security? How do we quickly secure the doors for these sorts of button down incidents? Because it's not the same as being told that there's an active attacker on a neighboring property. So Cassandra, I saw that you already noted in there that it kind of depends. It starts with security, but you'll pull support from other areas as needed. But anybody, Delwin, Andrew, Chris?
Yeah, so in Central Zone, one of the things that we have learned from this and other incident is that limited amount of security staff and manually labor intensive to go through all the doors, secure all the doors. So what we are starting to look at is what doors can we put on secure that we can actually press one button and those main doors are locked. And then we know how much doors we will actually have to lock manually by security staff. So it's a tedious process.
Yeah, we're lucky that we've heavily invested in badge access on most external doors, and otherwise they're likely going to be emergency fire exits if they're not. So they're secure 99% of the time anyways. So we can, with the flip of a switch, secure a lot of our external doors relatively quickly. And then we can utilize our security resources to go check if we know there's known areas that either historically haven't been as cooperative as automatic shutdowns, or those fire exits that some we like to think staff never prop them open, but sometimes they do. Is make sure those are secure. But in all the instances as well that we had outside of the car fire, but that was more of an air handling vent versus doors. There was a bit of time as well to make those assessments and put the measures in place before the threat became dire. Now, if something happened to that rail line 50 feet behind my one hospital, I could be talking about something different at a future presentation. But as it stands in my experience, you have a little bit of time that it's not similar to an active attacker where you're dealing in seconds to maybe minutes. You have usually about 20 minutes of grace period to kind of get things organized, at least before things get kind of more dangerous.
I'll pipe in here from my own organization's perspective as well, because this has come up and we tied it back to, I think Cassandra had also mentioned occasions where this might get used for something like a code amber, so a missing child, is that we recognize here that we might need to tap into some of the departments that have those egress points. And so we have assigned units to do that if they're a 24-hour department and they're in proximity to one of those entrances. And then it really is, like you said, Delwin, like there's limited security for many of our organizations, and it's a lot of square footage for them to cover. So the feasibility of having one of them stationed at every possible entrance point would just, it's not something that we can do. So certainly trying to tap into it when we don't have the ability to do that single push button response. Kassondra, your hand's back up.
Yes, I should have said, so from our part, our security team initiates the hold and secure. So they actually have pre-made packages. So they grab the packages that actually contain tape and pre-made signs. And then one package is for the checkpoint, checkpoint option A, and the other package is for checkpoint option B. And then they go to their list of doors, post the signs up, and then report back to the team lead, who will give them directions on their next steps. So we get our signage up quite quickly from the security team, but then depending on the time of day is then when we initiate work with our volunteers. So we may already have volunteers sitting in front of an info desk. So they'll just take over the door and coordination with the people at that door, because that's already what they're doing. And at 10 o'clock at night, if this happens, it doesn't matter. Half the doors are already locked anyway. So it's not really that big a deal where if anybody's monitoring the door in that sense. And we do lock our doors to staff badges as well. So it is one checkpoint for everybody.
I think some changes perhaps have come about since the era of COVID, where we had more doors open prior to that. And now we are much more accustomed to having fewer of those entrance points, which would make responding to these types of situations a bit easier. Chris, your hand is up.
Just to add to Delwin's point and really echo Kassondra's point that she just brought up, in our access control plans, we also have signage that security will initially implement and put on the doors and direct them to the correct doors. And for sites that we don't have the luxury of installing secure widespread throughout the campus, we have done security walkthroughs to see how feasible it is to add secure. And for sites where it's less feasible, we've begun to utilize our unit leads to implement access control within their departments. And then that's been the site-wide approach in those situations.
So now I have a big question that was also in the Q&A, but I figured we would get to this point, which is, wow, the downstream impacts of actually shutting off your air handling units and so on. Wanted to touch on a couple of things with this, but obviously we've heard from more than one presenter that this is time intensive, and then the downstream impacts. So let's talk a little bit more about what happens, how we go about shutting them down, and who's getting hit by having those down, because again, our audience might not be aware. So who wants to jump in first? Oh, Kassondra, your hand's up.
Yeah, so we have had to look into this. Partially, obviously, we don't want to cause some of the impacts when not needed. That's one of the reasons our wildfire smokes and things like that were pulled into a separate plan, because we could have more control over that. We didn't want to just initiate a button down, which the button down is supposed to be for an emergency. That right now we have to do it, which is a very different scenario than we need to look at something for a little prolonged. How do we maintain our hospital? It also came about, so we actually do have our little section in our code brown, which we have usually for chemical spills, but we've also put in a section there for noxious odors to also stop staff from just pulling the fire alarms and stuff, which in the old buildings literally shuts down all the ventilation as well. Because we had a lot of trouble here in Milton when we, a lot of new staff coming in, because I believe it's a mushroom farm quite close that creates some pretty interesting odors that can come into this building. And we were getting a lot of staff reporting in that there's a possibility of fire smells and things like that. So we had to look at different ways to do this. And that's kind of how we've dealt with some of that, to give us more control and not cause those downstream impacts without them being a real emergency situation. That's an immediate emergency situation that's requiring them. So that gives us that time to pull the right teams together and really figure out what is the best way to handle this situation so that we don't cause a lot of those downstream problems.
Anybody else want to touch on this? Delwin?
Yeah, in Central Zone, actually in the entire Nova Scotia Health, most of the air handling units are controlled by the facilities maintenance team. Before a decision is made for a shutting down of that system, it has to be done with APREP, Occupational Health and Safety, and the leadership, along with FMS. And the discussion about what are some of the impacts or the negative consequences, negative pressure will be impacted, all of those things are weighed. How quick can we really get in touch with the fire department to get a sense of when this thing is going to end so that we have a sense of how long the system is going to be shut down for? All of those are communicated and discussed before. Now, as everyone mentioned during the presentation, it's labor intensive. We're talking a lot of system and it takes a long for this scenario. It took us 45 minutes from the start of shutting down one to the end, 45 minutes shutting down, and we're talking about 5 buildings.
Excellent. Yeah, that's what I also wanted to touch on too. There is the actual time. So it's a pro and a con. Delwin, Andrew, and Kassondra, I mean, recently that you've been through some experiences where you have now had to go through this. But I think, you know, many folks on the call, luckily, have not had to go through one of these urgent situations where shutting down, I know, I'm like, knock on wood, whoever is, you know, but it's that time. So Delwin, if you're saying it's 45 minutes to go through that process, and that's after having that dialogue as a team to discuss, is this the step we're going to take? That's something that we have to keep in mind when we're saying these are the steps that we're going to do in the order that we're going to do them in. Question to folks: do you ever drill this? Do we have any exercises as teams about button down? This seems like maybe one of those less flashy codes for many folks that, unlike having a monthly fire drill, who's having exercises around button down? Andrew.
Yeah, so we've again, because the risk profile for the community, but also just the number of experiences we've had is we do typically rotate it into our regular command center training. We do when we do review our infrastructure failure button down policies, we specifically ask FM engineering, how long does it take to shut down total air handling? Obviously, they can, if they, in the case of Mumsy, they only had to shut down one particular vent, so it was a bit more tactical and surgical. Pardon the pun, I guess, because the ORs were impacted, but much more, yeah, surgical to do, and they were able to do it relatively quickly. As Delwin was mentioning, if you want to shut down the whole system, that is, and for how long? Because then you also have to consider how long does it take to get everything back online. You always run the risk as well whenever we're shutting things down. You fully, you know, hopefully they turn back on with no issues. We do incorporate it. Actually, I think recently, as 2 months ago, I incorporated it as one of the scenarios for our command teams to deal with. And then it also asks the clinical teams, what impact does that have on your patient care? If it is 40 degrees with the humidity outside and we lose air conditioning because we have to shut down for air quality, how long is that sustainable before we start seeing health concerns for our patients? And you know, are we delaying appointments, outpatients, community health even as well for our staff members, starting to incorporate that into some of the scenarios and planning as that service grows and grows in popularity. So it's something that's quite important. And if you haven't done so yet, ask your engineering facilities teams, if we had to turn the system off, how long would it take? Obviously something you don't want to really do on a full scale. You might be able to do it, say, overnight on a good temperature when it's, you know, good weather and good temperature, but it's one of those harder ones to fully test without having those impacts.
All starts with a discussion. I'll take one last bit of feedback. I think, Chris, you had your hand up, and then we'll wrap it up. Chris?
Yeah, I noticed the time, so I put my hand back down. But I just wanted to add to that from the incident, it reinforced the need to include ventilation system testing and shutdown procedures, as well as future drills and training around that. Outside of that, with access control, lockdown, and shelter in place, we're also in the process of testing that at 3 of our biggest sites here in Central Zone to see what that timeline looks like to do a full lockdown of the site, and then kind of work our way down from there once we get an idea of each site, what that time looks like.
That's great. It's a really good way to end things with a variety of different considerations for how we can improve going forward. Everything from the hold and secure to just the facilities testing component. I appreciate everybody's time today, including our audience who's with us for a few minutes past the hour. You just never know how the topic's going to go, and I think there's a lot of variables to this. And as we continue to experience, wildfire season and smog effects and different emergent situations, we'll have more case studies to bring in a future panel, I'm sure, on this topic. If folks have any questions that they feel didn't get answered today, you can email those to our colleague and coordinator, Francesco, here with York University. I also want to note that we have a little break after this session. We will not be having a talk in September. We will have some vacation time, but we will regroup and be back in the fall. So we welcome everybody to come back then and take part. I just want to say thank you again to all of the panelists. Really, really appreciate you sharing some personal takeaways from your organizations, as well as answering the questions that myself and the audience had. So thank you so much for your time. Francesco, final word, over to you.
Yeah, thank you so much. I also want to quickly echo my thanks to all of you for being part of our panel today. Thank you, Misha, for helping us put the session together and the whole series together, really, and for moderating as always. And thank you to everyone in the audience for taking the time to join us today. It's great to be back after having July off, and as Misha mentioned, we'll have Saturday off as well. Or sorry, September off as well. So we'll be back in October with the rest of the sessions for the year. So for now, I've shared our social media for CFAL York here in the chat if you'd like to go back and rewatch any of the recordings or this session recording while we're away. And I'll also just share my email in case anybody wants to follow up with me about anything in this session or any of the previous sessions as well, and I'd be happy to pass your messages, questions, comments along to the panelists. So yeah, with that, thank you so much, and we look forward to seeing you all in September.
Thanks for